we're representing the team at Great Ormond Street, and as you can see, we have a large team, and our lead consultant is Dr. Antonia Dastamani, and she sends her best wishes, and unfortunately she's not able to attend today. So the presentation is the journey of hyperinsulinism. So I just want to go backwards a little bit before we can go forwards. So thinking about the journey and what hyperinsulinism looked like in the past. So over 100 years ago, there was the first discovery of hyperinsulinic hypoglycemia, and that was in a book called The Discovery of Insulin. 70 years ago, there was a family in America, and they identified that it was a genetic disorder. 60 years ago, diazoxide was found. It was approved for the treatment as the first and only approved treatment for hyperinsulinism. 50 years ago, a contemporary of Sir Ainslie Green, who's here, who was Dr. Stanley and Dr. Baker, in an article described the diagnostic criteria of how to diagnose children with hyperinsulinism. 24 years ago, the potassium channel was found, and you'll hear about the potassium channel on the beta cell on this presentation. And then 17 years ago, in Finland, they used first the 18F-DOPA for PET scans. Since then, there's been an explosion of genetics, and certainly I'm looking at the Exeter team over there who will take you and talk further in their presentations about the genetic discoveries. So first of all, we're going to go and look at what's normal. This will be very brief. So I'll use the pointer. This is very, very simple. So your child will eat or have a feed, and the glucose level will rise. This stimulates the beta cell in the pancreas to produce insulin. Insulin is the only hormone that reduces the blood glucose level. So, and then if your child fasts overnight, the glucose is low, and the alpha cells in the pancreas release glucagon. That tells the body to use up glucose that's stored predominantly in the liver. This process keeps the blood glucose level, this is normal, within a balanced state, so within homeostasis. So now we're looking at the normal beta cell. The resting beta cell. There's no glucose around. This cell, the potassium channel on the cell membrane stays open. This is a hyperpolarized cell membrane, and the calcium channel is closed. And that means insulin stays within the cell. So low glucose, no insulin. This is the glucose stimulated state. So you've got glucose going into the cell. There's a cascade of metabolic responses that happen there. There's an increased ratio of energy within the cell, and this closes this potassium channel. This potassium channel, then the membrane depolarizes and the calcium channel opens, and insulin is released. So you have high glucose, and then insulin is released. So the metabolic and endocrine changes that happen at birth. At birth, a healthy newborn infant must adapt to independent existence outside of the womb. There's various mechanisms release the glucose at this time. So the endocrine responses are to increase blood glucose levels. These hormones are released. And then the metabolic responses release fuels, various fuels that increase the blood glucose level. But this period is we know there's a transitional period where soon after birth, the infant must adapt to existence outside of the womb. And this is called the transitional period. Now, is there a consensus to the treatment threshold? This is beyond the scope of this presentation, but we want to reassure you that there's many experts within the field looking at evidence and monitoring and updating guidelines. And the most recent guideline that's been published in 2023, that's been updated, is the British Association of Perinatal Medicine. And we want to reassure you that endocrinologists, paediatric endocrinologists, were on the expert panel of this, advising about hyperinsulinism. So that's very reassuring. Regardless of the treatment threshold and acknowledging the discussions to avoid over-treatment, it's vital to keep these babies safe. So we need to identify those infants that are at risk. So addressing some of the topics that you've posted already, there's one that is, could or should hyperinsulinism be added to the newborn screening? Newborn screening is at day 5 to 7. Is that too late to diagnose hyperinsulinism? What type of screening should be offered? One suggestion that we've recently heard about is could or should blood glucose levels and, very importantly, ketone bodies, the protective fuels, be checked pre-feed at 48 hours after birth. Infants in the UK sometimes are discharged at 12 hours, 24 hours. Who and how should that look? But please be reassured, this is work in progress. It's being discussed, and experts are trying to figure it out. So looking at one of the guidelines that is in place is the Paediatric Endocrine Society, and that's 2015. And as we said, we want to recognise those infants that are at risk. So here, these are the infants that they identify that should be screened. So any infant with symptoms of hypoglycemia, infants that are large, born large, without diabetes, or the mother could have diabetes, those infants need to be screened. Perinatal stress, any stress around birth, treatment for hypertension in the mother, labetalol, if they've been on a medication called labetalol, intrauterine growth retardation, babies that are small for dates, postnatal conditions such as polythysemia, hypothermia, prematurity, post-maturity, any history of genetic forms of hypoglycemia, and syndromes such as Kabuki, Beckwith-Wiedemann, abnormal midline defects. All these babies should be screened. Now we're looking at those infants that we need to exclude persistent hypoglycemia before they get discharged. Any infant that's had hypoglycemia, especially those that have needed treatment on IV fluids. And this is the recommendations from this guideline, is the inability to consistently maintain a pre-feed blood glucose level above 2.7 and up to 48 hours, that transitional period, and then post 48 hours above 3.3. Family history of genetic forms of hypoglycemia and syndromes. But I want to share with you that in the UK, so this is a guideline from the Paediatric Endocrine Society, but in the UK there's a group of experts that have been working together on a guideline, and I'll read this. They're called, the guidelines called a UK Collaborative Consensus for Standardising Practice in the Management of Hyperinsulinism, and it's awaiting confirmation from the British Society of Paediatric Endocrinology and Diabetology. And they're saying, according to the experience of the UK consensus, a level of 3.0 is a reasonable compromise between 3.3 and the lower threshold of 2.6, and could be used for the practical threshold for investigating hyperinsulinism, particularly in the presence of hypoglycemia and a high increased infusion rate. So now we're looking at the symptoms, and I'm talking to you as families. You all know they're very, very different, and they can be non-specific. Some of your children don't show any symptoms, but at birth we're looking at any of those. But we do say to our colleagues, our midwifery colleagues, neonatologists, paediatricians, listen to parents. So many times we've heard mothers and fathers saying there was something quite not right. That infant was not feeding properly, was sleepy, was jittery. Red flags, take a blood glucose level. So the causes of hypoglycemia, we've got an infant who's got hypoglycemia. This just illustrates to you there's many, many causes of hypoglycemia. It's like giving the clinicians a jigsaw puzzle to put together, and they've got to rule other things out. One cause is hyperinsulinism, but they have to rule everything else out. So we need to collect the information, the clinical diet, the clinical presentation, the investigations, everything, the blood workup. So what is congenital hyperinsulinism? Here again, you've got your beta cell, your cartoon model of your beta cell. This is pouring out insulin because it's active, but there's no glucose coming in. So the diagnostic criteria is it's an inappropriate excessive insulin secretion from the beta cell, causing low blood glucose level, hypoglycemia, an inappropriately raised insulin, And then the protective fuels, these ketone bodies and fatty acids, are switched off. Insulin is such a powerful hormone that it switches off the body's ability to make other protective fuels. So that's what we're looking for. In the UK, depending on ethnicity, the incidence is between 1 in 2,500 and 1 in 40,000 live births. As you know, it mostly presents in the neonatal period, but can present later. We have instances of some infants showing signs of when they have focal lesions, but later in life. Protein sensitivity when they're starting to wean, having different diet introduced. It's heterogeneous, so diverse in presentation. We're looking at the investigations, the blood workup, the genetics, the histology. So our criteria for diagnosing hyperinsulinism. So here is the 3.0. This is for diagnostic purposes, not for treatment. You'll all have the 3.5 for treatment purposes, but this is for diagnosing hyperinsulinism. So we look for a low blood glucose level of 3.0, less than 3.0, a detectable insulin. We look for another molecule called the C-peptide, which is a polypeptide that stays in the blood a little bit longer than insulin. And we're looking for the low protective fuels, these ketone bodies, these fatty acids. We're looking at an increased infusion rate, and we're looking at all the other things that are normal. So trying to put that jigsaw puzzle together for our clinicians. So now we're looking at how do we categorize hyperinsulinism? That was another question on your questions that you posted up. Transient, congenital, postprandial. We've just put them in those criteria. So the transient, there's a list of sort of the red flags that we would look for, but they're the infants that respond to diazoxide, can come off treatment very quickly. They do not need to usually be on diazoxide for more than 6 months. And in our experience, in our cohort of patients, we're actually able to get them off the diazoxide about 3 to 4 months. The congenital hyperinsulinism, so these are some of the genetic causes of hyperinsulinism. This is on that potassium channel, and these are the metabolic cascade of responses within that cell. These are the infants and children who need treatment beyond 6 months. 50% of these will have positive genetics and causes identified. And then the postprandial hyperinsulinism, and these are infants and children who have abnormal gastrointestinal anatomy, where the absorption of a feed of food can be responsible for abnormal insulin control. So here's a flow chart that's on our UK guidelines, and I'll just take you through this. This is a bit of the journey. So you've got a diagnosis of hyperinsulinism. Firstly, going down the cascade of the diazoxide responsive. If they're on a small to medium dose of diazoxide and their glucose levels are fine, we're managing them well, they stay on medical management, and we continue. If they are on a larger dose of diazoxide, we'll send bloods for genetic analysis. We want to see if they've got a genetic cause. The genetics will guide us. If it's diffuse disease, we'll continue medical management. But if it indicates that either the genetics are negative or that it's a possible focal lesion, we'll proceed to an 18F Doppler scan. If that Doppler scan shows that we've got a focal lesion, we'll certainly talk to our surgeons about possibly curative surgery approach. If it indicates diffuse disease, we will continue medical management. But if they're unresponsive to diazoxide, we go along, again, the genetics, but we'll also use our second-line medication, which is a somatostatin receptor analog, octreotide you may have heard of, and lanreotide. And we'll try and do the medical management. We do all we can to save that pancreas. We want to medically manage these children with medicines and feed. Feeds are very important. The feeding regime is very important. If they are unresponsive, we do have to consider subtotal pancreatectomies. So that incorporates the journey that we're looking at. Here, I certainly won't be the expert on this slide. I'm looking at our Exeter team. However, at the moment we do 14 gene analysis, and the most common is this ABCC8 and KCNJ11 genes. But the genetics help us to identify the treatment plans and if further investigations are needed, looking and whether we need to do PET scans or not. Plus, if they're responsive to diazoxide, a lot of these other HNF4 alpha and GLUT1 maybe will be responsive to diazoxide. So here, this slide just shows grammatically where the genetic defect is within that cell. So that's quite nice just to illustrate to you. So I'm going to hand over now to Sophie, my colleague, to carry on and talk about the types of hyperinsulinism.
Okay, so firstly, we'll just look at the differences between focal hyperinsulinism and diffuse. So diffuse hyperinsulinism accounts for 60 to 70% of HI. We usually, like Claire said, follow the medical therapy with this, and in last case resort, we follow a near total pancreatectomy. In the focal pathway, these patients tend to have a lower birth weight, require a lower GIR, and a later presentation often. And this accounts for 30 to 40% of HI. And often, if a lesion can be identified, it can be curative. There's also atypical type of HI, and histopathologists can decipher this under microscope. Oh, sorry. If a focal lesion is identified, or if the genetics indicate a focal lesion, patients will have an 18F-DOPA PET CT scan. With our GOSH patients, we take them to UCLH to do this with one of the nurse specialists, and we follow a sedation pathway to do the scan. So once the scan's been done, this is what the images look like. So in the top image there, you can see the focal lesion. It's got more uptake from the DOPA. And then in the diffuse, you can see the whole pancreas there has got uptake from the DOPA. So we'll look at the medical management of HI now. So our goals of therapy in the immediate instances are to restore blood glucose levels to above 3.5 millimoles per litre. In the midterm, we aim for optimal treatment to maintain normal blood glucose levels and also encourage oral feeding. And then in the longer term, we aim to prevent any neurological damage by keeping the blood glucose level stable, promote a normal life and development. In the acute management, in the acute stages, again, we're stabilising that blood glucose level, keeping it above 3.5. We want central venous access, secure central venous access, so we can administer high concentrations of dextrose. We need an accurate fluid balance and frequent blood glucose monitoring, often hourly in the initial stages when we're making changes or when the child's unstable. These patients, we're aware they can have multiple different problems. It's not just the HI, so fluid overload can be an issue, problems related to the central line, which we obviously need, feeding issues and reflux. And at this time, it's a stressful time for the families, so we need to support them through this. So this is just a diagram just to show the different treatment options in the pathway. So we've got the medical management pathway, and usually this involves feeds and medications. And then we've also got the surgical management, and this can either be curative or it could not be curative. So this is the referral pathway. So I'll just talk you through the referral pathway. Patients have to meet certain criteria in order to be transferred to one of the highly specialised services. And this is the pathway we follow with all children. When we identify hypoglycemia, if it's not identified as possible HI, then this can follow a local endocrine pathway. However, if we're suspecting HI, usually the local centre will phone one of the highly specialised services for advice. If HI is confirmed with the criteria that Claire mentioned, and it's not requiring diazoxide and the blood glucose levels are stable, this can be managed locally. However, if they are requiring diazoxide, we then look at this transfer criteria to see if they need to be transferred to one of the specialised centres. So, for example, if they're not able to keep the blood glucose level above 3.5, if they're requiring diazoxide above 7 milligrams per kilo per day, if they're having difficulties with central access, for example. So if they're not meeting this transfer criteria, it can be managed locally as they're considered the patient's considered diazoxide responsive. We always advise a fast prior to discharge, which is appropriate for age. We offer shared care with the District General Hospital, and we follow up in one of the highly specialised service clinics. However, if they are needing to be transferred, we'll transfer and organise this urgently to one of the highly specialised centres. We offer an MDT approach, insert urgent central venous access, stabilise the blood glucose level, and if needed, we offer genetic testing, the 18F-DOPA scan, gastrostomy and surgery, if necessary. So this is our discharge checklist, and we just want to reassure you that this is used whether or not they're transferred to one of the specialised centres. So we make sure that all of this criteria is met before a patient is discharged. So, for example, completing a fast appropriate for age, making sure they've got everything, the discharge planning, the clinic appointment with GOSH, for example. So we'll look at the different medicines that are used here. So diazoxide is the first line treatment. This activates the potassium channel. This is the we always use diazoxide. We know that it can be unresponsive in some genetic causes, but usually when we've got the initial diagnosis of HI, we don't know the genetics, so we often trial diazoxide. Proglycin or E5 Pharma is the preferred solution, as we know this is effective in treating HI. Unfortunately, it doesn't come without side effects, diazoxide. As I'm sure you're aware, fluid retention is an issue. So we fluid restrict to 130 mils per kilo per day. Hypertrichosis, so increased hair growth, is a side effect. Appetite suppression in long-term use. Pulmonary hypertension, so we always do an echo before starting diazoxide to make sure that the normal cardiac function. Anemia and arrhythmia can also be an issue. So octreotide is the second line treatment. So if they're not responsive to diazoxide or not tolerating diazoxide, this is given subcutaneously, usually 6 hourly as a starting dose. And then once a child's 6 months of age, they can be moved on to lanreotide or sandostatin LAR, and this is given as a deep subcut or IM injection once a month. This also has side effects, so we monitor regularly. So every 6 months, we complete an ultrasound to check for gallstones and regular bloods. Another medical treatment you might have heard of or seen in hospital is glucagon. This increases the glucose release from the liver. This is given via subcutaneous or intravenous infusion in the initial stages, but you might have also heard of it as an emergency treatment. So it's given IM in emergencies, and some of you might have it as part of your hypoplan at home. There's also some research trials at the moment. You might have heard of dasiglucagon, and this is a very exciting time. So previously trialled treatments, sirolimus you may have heard of as being previously trialled. It's not routinely used anymore. It's an immunosuppressant, so patients have to be carefully selected to go onto this, and it's only used as a short-term and a last resort therapy. And nifedipine is another drug you might have heard of being used, but the side effect of this is hypertension. The future is a really exciting time in HI. There's lots of new research trials coming out soon, and a possible new isotope for PET scanning as well, so it's exciting. So we'll just talk about surgery really quickly. So there's different approaches to surgery. So with the focal HI, this can be curative, or unfortunately sometimes medications need to continue. And with a surgical approach in diffuse HI, this can cause 3 different options. So normal blood glucose levels, which is great. Obviously that's what we aim for. Sometimes the HI still remains, and but they're responsive to medical treatments at this time. And then thirdly, hyperglycemia can be a result of the near total pancreatectomy, and inevitably all children will develop diabetes if they have a near total pancreatectomy, but this can be straight after surgery as well. So there's many different professionals involved in the care of a child, and we are all working together to care for the child and the family. So just wanted to illustrate how many people are involved in the care, and there's many different professionals.
This is a slide that a parent shared with me many, many years ago, and it just stays with me. We're thinking about how parents feel. And she just said she was so fearful. She just wanted help. She didn't know how to cope with her child. And with the multidisciplinary team all wrapped around her, holding her hand on this journey, she had a light bulb moment. She felt she could cope. So I don't know whether that resonates with you as families as well. But it's a very powerful message, certainly to us as professionals, that we're needed still, which is good. So, I know you're having a talk later about psychology, but you're living with a chronic illness. There's a fear of the unknown, being isolated, loss of normality, emotional adjustment, your future expectations and health development. You live within an extended family. What do your family members understand about hyperesthytism? There's a burden of care. You've got to learn all new skills. Some parents go, we become nurses. You're still parents, and you've got identities. Increased risk of anxiety, depression. We know that's why it's important to have the whole multidisciplinary team approach. Social difficulties. Can you go out for an evening out? Who can you leave your child with? Are you going to go back to work? Who can administer octreotide at home? can those infants go back to school? So, and also your child's illness dominates the lives of the whole family, and you've got siblings, you've got a life to live. So we do understand that, and that's. So moving on, our psychologist just shared this one slide with us, saying it's really important to recognise that whilst there are periods when managing medical needs is really challenging and the biggest part of your life, but it's absolutely possible to live well with hyperinsulinism, and that it's really important to remember the other non-medical parts of your child's identity. HI is one bit of them. So what else are they good at? What's their identity? What other things do they enjoy? What are their characteristics? What are their strengths? I'm not going to dwell on this. Development is being discussed with our physio and with your psychologist. But we want to say to you that many children live very well and have no neurological or developmental concerns. Have we recognised that many do as well? And that is becoming more and more evident. And certainly if you've got any clinical concerns, you must raise that with your medical teams. And if clinically identified, an MRI brain will be arranged. But certainly we hear from parents saying that it's when they're with their peer groups that they identified just subtle changes, especially going to school, not keeping up with their peer groups possibly as well, and the memory and switching and dividing attention, looking at the whiteboard and then being asked to do another task and quite not being able to do those. But it's really important that we get to, your child gets to reach their full potential. So speak out. I know you're having talks about educational healthcare plans and things like that. So do be vocal, and we're 100% behind you. Coming into hospital, stressful time, investigations, we involve play specialists, psychology. Going to school, educational healthcare plans, get letters of support for your children. We as nurse specialists go to schools, we do it remotely, in person, teaching schools about hyperinsulinism, attending appeal meetings, teaching community nursing teams about what hyperinsulinism is. Local teams don't understand what it is. Review bodies don't understand what it is. So we're there to help you, reviewing individual care plans. So the role of the clinical nurse specialist is what we do, Sophie, myself and Kate and other representatives in the audience. So we join you on your journey, we hold your hand, we're your advocate, we're your point of contact, we provide education, we're certainly very complex discharge planning can be taken place. We want to empower you to be able to cope at home, have the skills and knowledge, equipment and the whole team around you to be able to prevent repeated hospital admissions. Once you leave hospital, you want to feel that you can then settle down into a routine. And again, as I said, we are resources for local health teams and education teams. We do all the teaching, including blood glucose monitoring, if you have a CGMS in place, recognising and treating hypo plans, illness plans, administration of medicines, feeding plans. This is a resource that we've just put together. We've been really successful at administering lanreotide at home. Parents learn the skills to do this and avoid repeated hospital admissions. Hypo treatment can go on to glucose juice and tablets in the future. Now, NHS England, as you realise from the presentation and from your own journey, is complex, and NHS England have recognised that it's a rare and complex condition. For this reason, they fund highly specialised services, and certainly in the north it's Northshire, Alderhay and Manchester, and in the south it's Great Ormond Street. And we have to work collaboratively, we meet frequently, and we have to offer diagnostic facilities and treatment options, proceed to surgical treatment and have access to specialised surgeons. We have to continually monitor risk and governance to ensure treatment plans are effective, and we have to meet with our commissioners yearly. We're very proud to say that both Northshire and Great Ormond Street have been awarded the Centre of Excellence. 6 hospitals and units internationally have been awarded this. You're part of the parents group. You're supported and enveloped within this parents group. But you've got your medical teams, you've got your commissioners as well, and you've got CHI International as well, who are working with groups called the Clinical Research Network Groups, and they do the global registry as well. So take-home messages from this presentation and from us as professionals is symptoms are diverse, heterogeneous in nature. Children with hyperinsulinism do not make alternative fuels when hypoglycemic, so they are at risk, especially in the first few years of life, to brain injury. It's important to recognise and get prompt treatment plans in place, and all patients are individual. One thing works for one patient, another thing doesn't work. That same thing doesn't work for the other patient, another patient. And as children get older, we haven't talked about older patients and transition, and certainly Sir Ainsley Green has met recently with 2 of his older patients that are now young adults, and it's exciting to see them in that journey. Always ask for help. If there's any concerns, please ask for help. Your team are there for you. And it's a really exciting time with the explosion of knowledge and possibilities. The research that is going on, and you've got some representatives of the research teams here who are looking at new treatments for hyperinsulinism. There's so many expert minds now working nationally and internationally. So our last message to you is we all need to join hands together. We're all on this journey together, and it's going to be a bright future for hyperinsulinism. So we want to thank you for inviting us. We want to acknowledge those people that are part of our team, and our contact details are there.
Thank you very much. Thank you.
Yes, I'm Carrie. I'm one of the physios at Great Ormond Street Hospital, and I'm just going to spend just a couple of minutes with you talking a bit about development and how that fits in with HI. So a physio's main job is in neurodevelopment. So, and I'm going to unpack a bit more of that in the next slide, but I look at how children move, I look at how they're developing, and I look at any associated difficulties with movement. Say if there's been seizures or something that might have impacted the brain, I look at how to support the children with that. So that's what I do. So neurodevelopment, obviously we shorten it quite often to just development, but it is actually a whole 25-year journey. And I wanted to just share that a bit with you because I think people think about development as just those early gross motor skills. Are they rolling? Are they sitting? Are they standing and walking? Which are really, really important. But there's also visual development, how we develop what we see, how we develop what motivates us through vision. Fine motor, how we hold a pen, how we manipulate small toys. Social development's really important, how we interact with our families, friends, other people. Communication development is obviously really critical. Problem solving, attention, and decision making, they're all parts of neurodevelopment. It's all how the brain creates the pathways for us to be able to learn, do all those things. So it's a big, long journey. And people think that development is just like this picture on the left, just like little blocks stacked on top of one another. Like my child learns to do this, and then on top they'll learn this and that. But actually the reality, especially for a child that's been hospitalised or has any early challenges, is it's a bit more like the picture on the right. It's a bit more chaotic. It fits together, everything's linked, but there might be gaps. There may be ways that children learn something a new way, a different way, you know, round the top of something they've missed. So it's really important to focus on that because it's important that your child gets to be in front of the right person at the right time to help with their developmental needs. I made a little timeline. I've been a physio for like 25 years and worked in development all that time. And I find that these are the key points where people have queries or maybe people notice about development. So I just thought I'd share those because that's really important to know where you can get help for each. So at birth, we're thinking a lot about visual development. Can my child see me? Can they hear me a bit? Are they smiling? We think about, are they moving their arms and legs? Are they going to roll? So the early birth things, I guess, the kind of skills are the things that are most evident. And if your child's not doing those, it will be kind of obvious then. We're not thinking about their impulsivity and decision making then, you know. So we just get there. Then we often find when children might be walking, pottering around, they're getting ready to go nursery or preschool, and all of a sudden we think they're not running the same as their friends, they're not jumping. I don't know if I can get them on a scooter. I'm beginning to notice that maybe some of those skills are missing. I don't know if they'll be safe in a playground where they get knocked over, they don't feel as robust. So they're the things that people notice at kind of nursery time. And then when it comes to school, people often say they're a bit fidgety, their attention's not good, they're not holding a pen. I just feel like that something's not quite right, and there's lots of reasons why that might be, but that's the thing that people notice early school years. Then secondary school, it's all about being in different places at different times. It's about problem solving. It's about working out your homework, your executive functions, how to plan things and execute things. And they become quite obvious when secondary school starts. And then adulthood, still way into your 20s, you're still developing how you make decisions and stop being so impulsive. So it's a long line. Lots of things can flag up at any different time. And there are people out there that can help with each different challenge. But I just wanted to show, oh yeah, that's right, sorry. So we at Great Ormond Street have been particularly looking at early development, just done a small project over this last year. So in early development, I'm looking mainly at gross motor skills. As I explained, that's the thing that's obvious. And I use this test that gives me a score for how the children are moving, and I can describe that against to what is typical. So here's my results here. And I don't know if you can, there's a lot of data on there, but there's a blue line that tracks up the middle and goes flat at the top. And that's typical. That's what, if you imagine when your child plots their weight, they talk about the 50th centile. So that blue line there is the 50th centile. And here's all my children with HI, all plotted on there. And you can see that it tells me quite a few things. It tells me that in a typical population of any child, I should see a big spread of people above the line and below the line. That would be typical. But I'm not getting many children above the line. I'm getting some on the line, but not above. So it shows me that maybe in the early days there is an impact on development. Also, there's a kind of a big deviation. I don't know how to do this. Here, this big deviation here about 8, 9, 10 months, like that. There's a few children that really come away from the line. And when I looked at who those children were, they were all children that had hospital admissions over 100 days. So they're the children with more complex, hard to manage, and in that just environment that's not conducive to getting your early development. There was no link with genetics. There was no link with birth weight, anything like that. It was the children that were in hospital a long time. But you can see that all of the children, they all hit that top line. That top line shows that they're walking safely and they can stop. So the children all get in there, but they're not. But they seem like they're a bit behind. They do need to be a bit encouraged. So out of that, what we'd like to do step forward is we would like to have a provision for assessing and meeting developmental needs for children. That's not been formalised under like the current service, and we would like that to happen. And we'd like to create some resources for families, maybe some videos for different age points so that people could access them to know what's typical at that age and how to encourage your child's development. So that's what we're looking for the future. And that's all for me.
Thank you so much. Thank you so much.